very good morning and warm welcome to the speakers and all the participants to the webinar by Andhra Pradesh Audiologists and Speech Language Pathologists Association, which is associated with Indian Speech Language Hearing Association. We all gathered on this virtual platform on the occasion of World Voice Awareness Day. I thank each and everyone for taking time to join us today. Today we have our renowned speakers, Dr. Sanjay Subbiah sir, Professor Prakash Boominathan sir, and panelists, Mrs. R. Sirisha ma'am, Mr. Shekar Reddy sir, and moderator, Mrs. G. Lakshmi ma'am. So quickly moving on to our first talk by Dr. Sanjay Subbiah sir on muscle tension dysphonia and ENT surgeon's perspective. I would like to introduce about Dr. Sanjay Subbiah sir. So, sir, currently running a voice and swallowing clinic in Bangalore, India, and visiting neurolaryngologist at NIMHANS, Bangalore. Sir is skills trained in video stroboscopy, singing voice and speaking voice assessments. Experienced in thyroplasty, Botox injection, fat injection, routine laryngeal surgeries, voice therapy, and laryngeal manipulations. And also, sir trained in professional voice assessment and treatment. Successfully running a clinic exclusively for professional voice users, and also trained in fluoroscopy, modified barium swallow, and fees for swallowing evaluation and management. So has experience in private practice at MS ENT Center. Also assistant professor in KIMS Bangalore from 2000 to 2008. Also was an UG examiner and also for the PG guide. And ENT specialist at St. Martha's Hospital from 1996 to 2000. Sir have done his MBBS at Bangalore University in the year 1988 and MS ENT at Kuvempu University in the year 1992. And sir have done his fellowship in phonosurgery awarded by the Association of Phonosurgeons of India under the guidance of eminent laryngologist Dr. Jaikumar Menon. Sir has awarded with many awards with Best Paper Award at 26th All India Rhinology Society Conference 2003 and 10th Association of Phonosurgeons of Indian Conference in the year 2014. Also presented many papers and invited as faculty at numerous national and state conferences. Also published articles in national and international journals. Have been a faculty in numerous professional voice care seminars and workshops. Also conducted numerous workshops related to swallowing. Written a chapter in the textbook of laryngology published by the Association of Phonosurgeons of India. We welcome you, sir.
Thank you very much, madam, for the nice words. If you allow me to share my screen, I can.
I shared, sir.
Are you able to see my screen?
Yes, sir.
Yes.
Okay, and my voice also is audible, isn't it?
Yes, sir.
Yeah. Okay. I thank Lakshmi and the organizers for inviting me and this opportunity to speak here. It's very nice to see a lot of familiar names and faces whom I met a few months back in Visakhapatnam. So it's nice to be again among you all, and nice to meet Dr. Prakash after a long time. Is a thing. So I will start with my presentation. It's basically I talk about muscle tension dysphonia, ENT surgeons perspective. So just a brief background as to why we need a new condition called muscle, or why was there a need to describe a new condition? See, most of us or many of us who work with voice, we know that we see a lot of or quite a few of dysphonia or disordered voice. But then on laryngoscopy, you see there is a normal anatomical and neurological picture. Then in certain times, we also see there is a minor or a small laryngology pathology, but the voice is very disordered. And even sometimes you have a similar laryngoscopic pathology, but which which has different voices. And then sometimes we see thyroplasty we do for vocal fold paralysis. But after that, the voice still remains a little dysphonic or it is disordered. Earlier, all this type of scenarios were bracketed under functional dysphonia. They thought it was a psychological problem. But then afterwards, as people started to study and observe these patients, Orson was the first in 1990. He suggested that in many of these voice disorders, there is excess musculoskeletal tension. And this muscle tension might be the primary cause or secondary cause of dysphonia. And then afterwards, there was a nice paper by Morrison and Ramage, and where they described this entity of muscle tension dysphonia. So where they said those so-called cases, which we all assume as functional dysphonia, in which there was a lot of muscle tension, they are not actually functional dysphonia, but they are muscle tension dysphonia. So this is how they first described this condition, and this came into being. Basically, if you look into the textbook, there are a lot of names. I've just written a few. You can, the whole page, you can have a lot of names, is a thing. So to summarize, muscle tension dysphonia or MTD, described as a condition in which there is excessive tension of the extrinsic or intrinsic laryngeal muscles. I hope at least definition-wise, we are clear as to what we mean by muscle tension dysphonia. But then afterwards, after we described a condition like muscle tension dysphonia, then we realized that literally in all cases of voice problems, you will have some amount of muscle tension. So then suppose the muscle tension is secondary to some vocal fold pathology, like say there is a polyp, there is a cyst or a mass growth in the vocal fold, and the muscle tension is secondary to that, they are called secondary MTD. If no anatomical or neurological issue is seen on laryngoscopy, still there is muscle tension. Those we refer them as primary MTD. So you can see that this is a video. There is a small cyst and then there is so much muscle tension. I'll explain briefly. This is a growth. So you can see that it is a huge growth, but you can't see it. The muscle tension is so much, so which can. So what are the possible causes of muscle tension dysphonia? I think speech pathologists, most of you all will be aware of this, or what is abuse and misuse of vocal mechanisms. Learning adaptation following an upper respiratory tract infection, compensation for an underlying vocal pathology, or laryngeal irritation leading to increased tone like reflex, postnasal drip, or thing. See what happens now. You imagine that you have a walking style. Then if there is a sprain in your ankle, what will happen? 1 day or 2 days, you will take rest. After that, you will start limping, but you will move around. So limp is the compensation or adaptation which your body did to overcome the sprain in the ankle. So after 4 or 5 days or 1 week, what will happen? You will take medicines or something. The sprain in the ankle will become okay. But the limping, what you were doing, now it has become habitual. Without your conscious awareness, you have incorporated that limping into your style of walking. Something similar happens. Or what you can do is, after the limping goes, after the sprain in the ankle goes, you have limping, and then instead of undoing what all adaptations you did, you might do another layer of adaptation. So then what will happen? You will have layers and layers of adaptation. Similarly, if there is an upper respiratory tract infection, there is a reflex or something in which the vocal folds are congested or they are edematous. So if they're edematous, what will happen? Mass will increase, pitch will fall. So then the body only will do compensations to adapt and overcome this change. After some time, the upper respiratory tract infection will disappear. But the compensations, what an individual did, they have become habitual. So again, this compensation was for the edematous vocal folds. So again, after the edematous vocal folds will become normal, in the same style, if he talks, again, voice will change. So then again, they will do another layer of adaptation or compensation. So what will happen? They will have layers of compensation. They will try more hard. The end result is there is a lot of muscle tension. This is what I mean by learned adaptation following upper respiratory. Afterwards, it is habitual and they can't overcome that. Why in a few people they do this, whereas everyone will not have it, again, is a matter of there are other factors which predispose some individuals to this type of adaptations. One is psychological, personality, unresolved emotions. All of this can be a factor. And now recently, there is a lot of papers about auditory feedback, self-monitoring dysfunction. I am a big fan of this thing. I am doing a lot of work on this. And I feel this is one of the major reasons. I mean, I'm not saying all of them will have this, but one of the major reasons. I'll spend 1 or 2 slides explaining this, and then we will revert back to muscle tension dysphonia. See, you know that human speech, if you plot the F0 over a period of time, 5 seconds, the top line, if the F0 is same, it will be like a robotic voice or a machine voice. Naturally, in humans, what will happen? The F0 will vary up and down. This is what we call intonation, and this is very important for expression. So, once you create variation in a system, it becomes unstable. The variation must not be less, again, it is wrong. If variation is too much, again, it is wrong. So, for maintaining a proper variation to make sure the intended vocal output is the real vocal output, we have an auditory feedback system which monitors the voice. And this works by various reflexes, a Lombard effect, you know, delayed auditory feedback, you know, pitch shift reflex is also another reflexes which works at all this level. Suppose there is a disconnect in this system, the auditory feedback monitoring system is deranged, then it can lead to muscle tension dysphonia. This is what I mean by an impaired auditory feedback monitoring system. And recently, a lot of studies have also come out which say the existence of, again, central auditory processing disorders in a few cases of behavioral dysphonia. And rectifying this is also, it opens up new avenues, and it is also necessary for management of any behavioral or muscle tension dysphonia. Now, coming back to muscle tension dysphonia, they were some of the causes, and a recent cause, which I feel is very important, I have just briefly mentioned. 4 types of MTD have been described. The type 1 is at the level of the vocal folds. You have an open posterior glottic chink. And this actually can be associated with vocal nodules also, you can see. Then there are other types where the muscle tension is above the vocal folds. There in type 2, you can have the ventricular folds approximation, false vocal fold approximation. Type 3, you can anterior posterior compression. Type 4, you can have everything, both ventricular and anterior posterior compression. So this is videos I have just described to show you the laryngoscopic picture. Yeah. So you see a posterior glottic chink is there. This is a nodule with posterior glottic chink, type 1. Then you have type 2. You see that ventricular, the false vocal cords are phonetic. This is a sulcus with ventricular phonation. Type 3, you will have anterior posterior. And then this is a secondary MPD, vocal fold paralysis. You can see literally it is so bad I can't see the vocal folds. It is fully collapsing and it is impairing the visualization. These are still images, posterior glottic, ventricular phonation, anterior posterior, and complete closure of the glottis. So these are the 4 types of MTD which are described. Then again, another thing I want to show you, 3 patients of unilateral vocal fold paralysis. You just see each person is adapting in a different way. It is like having the limp I gave example, an ankle sprain. Everybody need not limp the same way. Each individual has his own way of limping. But here in voice, what will happen? What your final voice is dependent on what type of adaptation you do. I hope the voice is, you can hear the voice.
I'm working in the RSA. It's an IT solutions company, which is located in Whitefield. And I'm currently with my family in Child Cross.
I study MBA and doing surgery when I was 2.5 years old. And
So you see, the first patient had a breathy voice. Second lady had a high-pitched voice. It's still like a child, even though she's 18 years. And this last patient has a completely like a whispering, completely breathy. You can't even hear the voice. So each of the, all of them have the same vocal fold pathology, but each of them has adapted in a different way. This is what is the it is the muscle tension which has changed the voice. So in these type of cases, this is what I meant. You not only have to treat vocal fold paralysis, secondary adaptations also you should rectify. So this muscle tension dysphonia occurs, it is more common in women. 50, and in any voice clinic you see, 40 to 50% of cases will be muscle tension dysphonia. In fact, I keep joking sometimes. When I was doing a fellowship, I did ENT, then I specialized into voice, and I was doing my fellowship. I thought when I returned to Bangalore and I announced to everyone that I am now a voice specialist, I thought I will get pouring in of vocal polyps, cysts, and then every day I'll be operating. But then I realized that almost many of the ENT surgeons, they didn't refer polyp, cyst, or other type of cases. They referred all their muscle tension, dysphonia cases to me. They said, we did laryngoscopy, everything is normal, we don't know what to do. Now you are a voice specialist, you do. So then afterwards, it's just in a lighter way. So 50% of cases in any voice clinic will be muscle tension dysphonia. If you want to run a voice clinic without knowing this condition and without being able to help these patients, your voice clinic will not be a success, or it is not doing justice to its name. Then we often encounter many of the times when I clinically assess a patient, when I listen to the voice itself, I will have a rough estimate what type of pathology I can expect. Many of the times, even after working for so many years, whenever this muscle tension, they always mislead. The voices are so bad, I will think it can be this, that. But then many of the times I do a laryngoscopy, it is not. So you actually encounter very severely affected voice. And like I mentioned earlier, there is no unique quality. This is of muscle tension. This is not muscle tension. Like I mentioned, you can have all types of voices. Then patient's characteristic dysphonia will be the complaint. The other thing is vocal fatigue. They will characteristically tell doctor, I'm taking class nowadays. In 15 minutes, I get tired. One period, I can't go beyond that. Singers say, I can't reach high pitch. Fatigue, loss, vocal loss is a thing, vocal strain. And then afterwards, pain on phonation. So as usual, they would have seen an ENT surgeon or a general practitioner. He would have been bombarded with antibiotics, painkillers. Pain means they think it is infection, is a thing. This is a common complaint. Tightness, they feel tightness. Globus, as if something is stuck here. So he would have undergone CT scan, MRI, endoscopy, everything. And then inappropriate pitch and unable to project. These are some of the complaints we see in a person with muscle tension dysphonia. See, this is a vocal pyramid I have made, and this is my favorite slide. Wherever I go, I make sure I talk about it. See, as ENT surgeons, when we look at the vocal folds in laryngoscopy, we are looking at the tip of the iceberg. It is not the only problem. See, there are a lot of hidden issues. First of all is general, the behavior, the environment, the emotion, personality, general health of the individual. All of this will have an impact. And then you have, after all, vocal folds are nothing but two bands suspended in the airway. So they have, there is a lot of muscles, cartilage, joints, nerves, everything behind that, which makes it smooth, close, tense, flex, everything. So there can be an issue there also. And finally, the vocal folds. So unless we take the whole picture into consideration, our assessment or treatment will be incomplete. This is an integrated diagnostic model described by Dr. Robert Bastian. I like it a lot. So I have incorporated it into my vocal pyramid. You have a voice-focused history where you assess these things: behavior, environment, emotion, personality, health, all the type of job, everything. So you have to inquire and go into all those details. And then assessment of vocal capabilities, limitations, all that we make an assessment of the muscles, the joints, the cartilaginous nerves. And finally, laryngeal examination, which we do as to see the vocal folds. This is how you should assess. So voice-focused history means what? You establish your chronology. They will be characteristic, like I mentioned. They will tell doctor, I had upper respiratory tract infection. Every time cold, voice used to go. But within 1 week, I take medicines, it will come down. This time it's 1 month, 1.5 months. Even after taking medicine, the voice has not come back to normal. So these type of, whether he had, or I strained my voice. I mean, whatever is the history, you take all the chronology. And most important in muscle tension thing, or for any, we have to determine the motivation and resolving of the patient. How much is he motivated? Because I'm sure all of you and Prakash also will be speaking about voice therapy. Voice therapy is not a one-day shot. You fire, tuck, it goes. It's going to, they're going to come to you. How motivated are these patients to follow up with you, to practice? They need to change the way. All that is a little commitment. Then there are various symptom complexes, some diseases you have so you can, in that way, a little bit deduce some of the diseases. And talkative scale, I'll ask the patient. So this will, you can ask them only to tell in what will be your score. And most often than not, most of them will tell correctly. They will tell, yes, doctor, I'm a very talkative person. Or some other person will tell, no, I'm not a silent. I mean, I'm a silent person. Then evaluation, auditory evaluation is very important. You will hear the assessment. Like I mentioned, many of the times I hear the voice, I try to make an assessment and I try to make a picture in my mind, what might be the most probable lesion or cause for this. Pitch frequency also you'll see if it is appropriate for that age. Generally, this is not mandatory. Hyperfunctional will be low, hypofunctional will be high, like Dysphonia thing, you can see high, and low like muscle tension, you can see. Then you also test the loudness, breathiness, roughness, GRBS scale you have, so you can make an assessment. MPT is very important. Then the other general, like I mentioned in the vocal pyramid, muscles, the breath, all that make an issue. So you look at the posture, breathing, and many of the times you can also make them to do other vegetative sounds like coughing, grunting. That will sometimes I do that to assess the primal F0 of the patient. Then finally, as ENT surgeons, our favorite, we do laryngoscopy. You can either do a mirror examination, or we can do transnasal fiber optic or stroboscopy or rigid endoscopy we do. So this is a stroboscopy you can see. You can see the mucosal way. Then transnasal. So in this, you can go down up to the vocal fold level. You can do a more closer assessment. And sometimes I move the image from vertical to horizontal by the camera. So that will help you to, I mean, it's just a personal a tip, or I like it like that. Even small mucosal lesions I'll be able to make up. So you can do that. And then afterwards, the neck is very, very important. You have to examine the neck. You can see hypertonic, because I told you what is MTD, muscle tension, both intrinsic and extrinsic muscles. See, the larynx is like suspended. It is not like hand. It has two joints. It is suspended here. So all these muscles, they will determine how the larynx is placed and how it will be working. So imagine if all the muscles are tight and you compress the larynx, then how will it be able to do its work? So that's very important to look at the hypertonicity. There will be hypertonicity of the neck muscles, suprahyoid muscles. The larynx will be tense and tender. You touch it, it will be tight, and then a little bit you move, they'll say, don't, I mean, it's pain. Then high larynx, hyoid thing rises on phonation. Neck breathing will be there. Abdominal is held tight, and generally, like I said, emotional personality issues will also be there. Anxious aside, reduced MPT, acoustic, and those you will do. You can see that typical the neck breathing, the apex of the lungs are also, you can see the bulge, and you see the neck muscles are so tight. So tenderness is also very important. You can see greater cornu of the hyoid bone is one of the commonest area. Sometimes even in the inferior thyroid or trichothyroid place, you can see. Many of the times, if I see tenderness, I also do massage. And I mean, a few times, not always. When you do massage, you will be able to, with only the massage, I'll be able to see the voice is a thing. So yeah, so now I'll just, this video, kindly see tenderness I'm testing. You can see the eyes, see that I'm doing very soft. See there, so you know it. This is another boy I did. Then I did massage. This was his voice.
ನನ್ನ ಹೆಸರು ವೇದಾಂತ್. ನಮ್ಮಪ್ಪ ನಮ್ಮ ತಂದೆ ಹೆಸರು ಡಿಲ್ಲಿ ಬಾಬು. ನಮ್ಮಮ್ಮ ಹೆಸರು.
This is actually the voice after 1 week. His voice improved. I think that in between one video is missing. But many of the times, if you know massage, you can do, and you can help the patients immediately. Differential diagnosis. One of the commonest differential diagnosis you have to rule out with muscle tension is adductor spasmodic dysphonia. Because I told many of the times the laryngoscopic picture will be normal, then vocal tremor. So these are, I have some videos of that. See, there's a breathy, little rough voice. This is adductor spasmodic dysphonia. You will see vocal breaks. Then abductor, you will again see that breathing.
ಪ್ರತಿ ವಾಯ್ಸ್ ಪ್ರಾಬ್ಲಮ್ ನಾನು ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡೋದು ತಿಳಿಸ್ಬಿಟ್ಟೆ. ನಾನು ಮ್ಯಾರಿಡ್.
You can see flaring of the ala nasa, which was described by Dr. Jayakumar Menon, my teacher, in abductor spasmodic, then vocal tremor.
ಅಲ್ಲಿ ಬಹಳ ಸೌಂಡ್ ನನಗೆ ಈ ತರ ವಾಯ್ಸ್ ಆಗಿದೆ, ಬಹಳ ನಾನು ಡ್ರಾಮಾ ಎಲ್ಲ ಆಡ್ತೀನಿ, ತರ ವಾಯ್ಸ್ ಆಗಿದ್ದು ಒಂದು.
See, vocal tremors, the breaks are at regular rhythmic pattern, whereas in spasmodic, it is irregular. That is how, and plus other signs of tremor. In this case, you can see little head tremor also. These are some of the differential diagnosis of muscle tension dysphonia. And then before I end, just a lighter slide. So what happens, this is another common thing we see, that muscle tension, you make a diagnosis of muscle tension dysphonia. Patient is very worried. Some neighbor or relative would have seen something about cancer detection and thing, voice change, you have to go. They will come. Then I will make a diagnosis of saying that it is muscle tension dysphonia. They will ask what it is. And then I will explain there is nothing wrong in your larynx. Everything is normal. The way you are using, you have picked up some muscle tension. As soon as I stop explanation, they will tell, okay, doctor, thank you. Think that voice, I am not worried. I just wanted you to rule out that I don't have cancer. Thank you. And then leave. So the next job is difficult job for Prakash to convince the patients to undergo the treatment and then treat. I will end with this. This is, thank you very much.
Thank you so much, sir. Our next talk on strategies to handle hyperfunctional voice disorders by Professor Prakash Boominathan, sir. Before going into the talk, I would like to give brief introduction about sir. Professor Prakash Boominathan, sir, is currently the Principal of Faculty of Audiology and Speech Language Pathology at Sri Ramachandra Institute of Higher Education and Research, Deemed University, Chennai. He also serves as a Senior Consultant Speech Language Pathologist at Sri Ramachandra Medical University Hospital. He is a qualified clinical educator and adjunct faculty at Department of CSD at University of Toronto. He was the first rank holder during his undergraduation and a double gold medalist during post-graduation that he completed from the All India Institute of Speech and Hearing, University of Mysore. He received his Ph.D. in Speech Language and Hearing Sciences, his main specialty area on vocal dynamics of the singing voice, from Sri Ramachandra University. In the year 2005 to 6, he had received the prestigious Fulbright Research Fellowship. As part of fellowship, he visited University of Cincinnati, Ohio, and other voice centers in USA. He has been at Sri Ramachandra over the last 2 decades. His area of clinical focus and research are fluency and voice with emphasis on professional voice care. Sir has been closely involved in the establishment of Voice and Swallowing Clinic as a special clinic in Sri Ramachandra University Hospital. This included sensitizing, developing, and supporting interdisciplinary teamwork with ENT surgeons, SLPs, and musicians. He has conducted several workshops on voice care, assessment, and management, has over 70 publications, of which nearly 50 are in Scopus and Web of Science indexed. A few book chapters and 2 instructional DVDs on voice therapy to his credit. He is on the editorial board of several scientific journals such as Journal of Voice, ISHA, and ISHA, editorial board of several scientific journals such as Journal of Voice. Journal of Laryngology and Voice. He has to date successfully guided 5 PhD candidates and is currently guiding 3 PhD students and serves on 7 doctoral committees. Now he is currently president-elect in the year of 2023 to 24 of Indian Speech Language and Hearing Association and an expert member from the year 2022 to 25 of Speech and Hearing Committee of Rehabilitation Council of India. Professor Prakash was recognized with Teaching Excellence Award in the year 2019 by Sri Ramachandra Institute of Higher Education and Research. The Indian Speech Language and Hearing Association in 2023 bestowed on him the prestigious Dr. N. Ratna Oration Award for his exemplary service and research contribution in the field of speech language pathology. We welcome you, sir.
Good morning. Can you hear me?
Yes,
Am I
sir.
audible?
Yes, sir.
Thank you very much for the nice introduction, and good morning, friends of the Andhra Pradesh Association of Speech, Language and Hearing. It's a pleasure to be here with all of you on World Voice Day. And it's always a pleasure to listen to Dr. Sanjay Subbiah, and I thank you for this opportunity to share this platform with Sir. It's nice. We've had shared platforms in the past also, and I'm very glad that he set the right stage for the next part of the talk, where he says, how do we convince the patient and what do we do with it? Okay, so for the next half hour or so, I will be talking about how do we go about treating them, and a little repetition of what Sir has done. I'm going to be, can I share my slide?
Yes, sir.
Yes, sir. Yes, sir.
Yeah.
By the
Is
time,
it visible?
sir, not yet, sir. By the time Sir shares the slide, I would like to slightly announce and thank Dr. Sanjay Subbiah, sir, for his excellent video presentation about the patients and the differential diagnosis. And I would request Sir to please stay back for a little while for panel discussion and question answers. I'm sure many of them would have a lot of questions. Sir, you can go ahead. I'm sorry I had to announce this.
Thank you very much. Is it visible?
Yes, sir.
Yeah. It's on my first slide, right? Okay, so okay. Can you see me? And is it visible?
Yes, sir.
Okay. So let me continue with the strategies to handle hyperfunctional voice disorder, which primarily is sometimes the muscle tension dysphonia. So in the next half hour, what we will be talking is what is the current perspectives, what is the understanding of hyperfunctional voice disorder, what are the precipitating factors to hyperfunctional voice disorder. I would like to call it as precipitation than predisposing. Management approaches and some evidences from indigenous research. What are we doing in India? What are the findings? So let me start with the understanding. So Dr. Subbiah had nicely set the stage that it is seen as a functional disorder and how things have evolved from the 90s. From the 90s, after Morrison and Ramage coined in 1993, muscle tension dysphonia has been quite popular. But the changing perspective is now it is seen as sort of a muscle imbalance. Okay, the current understanding of the hyperfunctional voice disorder is a muscle imbalance, which is basically because of certain malregulation of the structures which are involved in the sound production. This is happening when the structures are intact and there is no neurological problem, but there is a sort of muscle imbalance because of a conflict between an activation and inhibition of the muscle activity. And this activation inhibition conflict happens because of two major things which again, Dr. Subbiah addressed, he says auditory feedback. I would make it little more broader. It is an impact of a sensory mechanism. It just not necessarily is auditory. It could be other senses also. There could be tactile, kinesthetic, proprioceptive, other feedbacks. When there is an imbalance there, then there is possibly an activation or hyperactivation of the vocal mechanism. The second cause or thing which is attributed for this muscle imbalance is a psychomotor mechanism. That is, it's just not a sensory feedback issue. It is also to deal with the way you are processing the voice output. Okay, how you perceive it in your mind and what sort of action or activation you do to your body functions. So an imbalance in psychomotor activity and a sensory mechanism can lead to a muscle imbalance, resulting in a mal-regulation of the functioning of the vocal cords, which is represented as a hyperfunctional voice use pattern, sometimes a disorder. Now, this is manifested in two basic ways. When there is muscle imbalance, the excessive muscle functioning is seen in both speaking or in singing. And this can happen as false chord adduction, which you see here. Can you see my prompt moving in the slide?
Yes.
Okay. So this is lateral compression of the false chord. And there is an anterior-posterior compression of the arytenoids towards the epiglottis. So these two are the two different manifestations, and this can happen separately or it can happen in combination. So in this video which you see, you're seeing that there is lateral compression initially, and then there is anterior-posterior compression also. This is like grade 3 muscle tension dysphonia, very severe muscle tension dysphonia. So these are the two ways in which the hyperfunction is expressed on the vocal system. Now, why are this hyperfunctioning happening? Why is this happening? What are the precipitators to this hyperfunction? We can categorize this under 4 different ways. It could be personal factors, environmental factors, psychological factors, and occupational factors. The personal factors, it may be dependent on the person itself, biological susceptibility to voice problems. Some people are generally more susceptible or vulnerable to develop vocal breakdowns when compared to others. So these people may always have certain amount of hyperfunction. This can also happen because of irregular or improper diet, which may lead to laryngopharyngeal reflux or gastroesophageal reflux. When a person does not drink adequate water, there will be hyperfunctioning of the system. So reduced hydration will also manifest or precipitate or lead to a hyperfunctioning of the system. So these 3 are considered as major personal factors. Some people are vulnerable, others because of irregular diet and reduced hydration will have a hyperfunctioning system. Environmental factors could be the work environment, the nature in which the people work. Like, for example, teachers. Many teachers manifest with hyperfunction because of the environment, work environment. They tend to talk louder, vocal loading happens. As a result of vocal loading, the system goes into a hyperfunctional state. Room acoustics, when the room is not conducive to speak, when there is so much of reverberation or when there is so much of background noise, then automatically the person has to put a little extra effort to produce sound, and that will manifest as a vocal hyperfunction. When people work in dusty environments or smoky environments or are exposed to dust and smoke, there will be reflexive tightening of the vocal cord. The vocal cords go into a tight adduction just to facilitate a coughing reflux. So that again, when repetitive cough can also manifest as a vocal hyperfunction. So these can be related to environmental factors. The third important thing is psychological factors. What sort of personality are these people? So many of people who are little aggressive in nature or impulsive in nature are perfectionistic in nature, type A personalities, often have vocal hyperfunction. The next is, how are we reacting to stressful situations? Everybody has stress in some form or the other, but some people learn to manage stress a little more conducive ways or in more productive ways than many others who may react to stress, and that will result in an overall tightening of the body, and the vocal function also will get more tighter. So how we are reacting to stress or anxiety will also lead to sort of vocal hyperfunction. The last factor which may lead to vocal hyperfunction is the occupation. The voice demand, like, a lawyer, teacher, person who is working in a restaurant, who is all the time in a noisy environment, singers, okay? Because of the nature of the thing, there is so much of vocal demand and need to use the voice in most unconducive environment. And also there is no time for the voice to recover. Inadequate recovery time will also manifest itself as a vocal hyperfunction. Many of these people will have fatigue, and when voice fatigue happens, you need to provide some rest for the system to resolve. But if the situation does not allow you to provide rest, and if you continue to engage yourself in talking, there is inadequate time for recovery, which will lead to a hyperfunctional state. So what I'm trying to say is, all these factors may lead to hyperfunction, and this hyperfunction is just not always a disorder. It is just a state of function. Okay, so even people who may not have typically a voice disorder can have a hyperfunctional state, which may eventually lead to a voice disorder, which means the person are at risk of developing voice disorders. So when the vocal function is always in hyperfunctional state, it can result in two different disorders. One could be non-phonotraumatic hyperfunction, which is called as a primary muscle tension dysphonia. Basically, because of the tightening of the muscle, the system does not have any secondary disorders, will not have any disease process on the vocal system. Phonotraumatic vocal hyperfunction, which means every time the voice is engaged in a wrong way and leads to secondary changes in the vocal muscle. That will lead us secondary muscle tension dysphonia, where you may develop a polyp, nodule, cyst, any other condition which may arise because of phonotrauma. So these are the two types of vocal hyperfunction, which can happen in any person. Most of people may have just primary muscle tension dysphonia, which is non-phonotraumatic, which is basically because of the four factors which I listed. Some of them may develop into phonotrauma related to vocal hyperfunction, which will cause secondary muscle tension dysphonia. In any case, we have to deal with these patients, and many of them may not require surgery unless there is a polyp or a cyst which requires surgical help. Most of them will require non-medical or non-surgical help, and that relies with the voice specialist who are working with them. So when you start therapy, before you start therapy, you need to have a comprehensive assessment, which again, Dr. Subbiah very neatly explained, where he says you need to address certain things. So here, basically, you have to look at three components. You need to look at the person, the physical system and the contributing factors, the lifestyle of the person, and the emotional overlay of the person. All of these are linked towards vocal hyperfunction. Now, this can be achieved, these assessment of these three basic entities can be achieved through subjective assessment and objective assessment. The subjective assessment is case history, reflux symptom index. We can use vocal health questionnaires, and physical and occupational aspects can be, again, there are indigenous questionnaires now. We have normatives for our own population, like voice disorder outcome profile, vocal fatigue index. All these are available. Patient reported outcome measures can be added. This will also give input on several aspects like social support, motivation of the person, what are the constructive coping strategies the person is doing, and what is the capacity for this person to reframe? How can he learn, or how ready is he for voice therapy suggestions? So as Dr. Subbiah said, no, it is important for you to convince this person. No cancer, I'm all right, I'm okay with this voice. The stage where he is led to you is to where you have to convince him, saying that it is important for you to work on quality of life so that it becomes much more easier. So what is his readiness for therapy? Now, all these are important. Along with that, aerodynamic, acoustic, stroboscopy, or at least video laryngoscopic images for you to know the baseline level. So once the assessment is done, we'll now go to therapy. So the focus here in my talk is more on therapy. Therapy, there are two approaches. You can go for indirect intervention and direct intervention. Indirect intervention basically focus on vocal hygiene, vocal health and pedagogy, and voice conservative counseling. Direct intervention, certain techniques we will discuss here. Now, indirect intervention, I basically focus on four basic aspects in vocal hygiene. One is basically to introduce or engage them to thinking that they have to drink a lot of water and frequently drink water. Drink water frequently. Increase the hydration. Every 15-20 minutes, keep sipping water. So automatically the friction reduces. The person gets less susceptible for vocal hyperfunction. Second is work on improving the vocal ambience. Make sure that the noise level in the room is reduced, the reverberation is reduced so that you can speak more effortlessly. Do everything to reduce GERD or laryngopharyngeal reflux. Eat the right sort of food, eat at right intervals, eat the right amount or the quantity. Eliminate phonotrauma. Don't engage in phonotraumatic behaviors like shouting, throat clearing, repetitive coughing, or using voice in unusual ways to call attention of people or for certain other reasons. So eliminate phonotrauma. So these four things have to be concentrated. The moment you focus on these four, many times the hyperfunction reduces. I want to emphasize here, voice rest is not a treatment for vocal hyperfunction. So do not provide rest, but instead you can provide or educate them for vocal naps. In between voice use, take some short periods of rest. But keeping quiet for 24 hours, 48 hours, 72 hours for 1 week, 2 weeks will not improve vocal hyperfunction. It will not have any effect on voice. So voice rest is not a treatment for vocal hyperfunction. Other indirect methods are providing some understanding of how sound is produced, what are the reasons for hyperfunction, what are the treatment options, what are life situations which are leading to stress, how are they reacting to stress, what is the cause for their problem, allowing them time to reflect on what is happening around them automatically allows them to settle with voice problems. Now we will spend a little more time understanding the direct intervention, which is the role which the speech language pathologists have to do. So there are several techniques which are available. I use very consistently these four different exercises: relaxation exercise, vocal function exercise, resonant voice exercises, and semi-occluded vocal tract exercises to reduce the vocal hyperfunction. All of these direct exercises work on the principles of exercise physiology and motor learning, principles of motor learning. Now, what does this exercise physiology says? It basically says that when you are working on skeletal muscles, the skeletal muscles, vocal cord muscles are skeletal muscles, which means they are very voluntary. You can provide the command and they will start working the way you command the vocal system. They are prone to fatigue. So if you provide some rest, it will recover from the fatigue. So the principles of exercise physiology are applicable for skeletal muscles, which means your vocal muscles will also work on the same principle. So when you see that the voice is getting overloaded, you need to slowly and gradually expose to these load so that the muscle will go into an adaptation and the muscle will start withstanding these overload. There are specific muscles which have to work for increasing the strength. And these muscles are basically based on the actions which are involved. So specificity principle means you are working on those muscles which are engaged in certain types of activities. What can the vocal cord do? Vocal cords can do only two types of actions. One, it can open, close. The second option is it can stretch, contract. What is important? What muscle is involved in opening? It is a posterior cricoarytenoid. What muscle is involved in closing? Lateral cricoarytenoid or interarytenoid, or a combination of these two. What is involved in stretching? Cricothyroid. What is involved in contraction? Thyroarytenoid. So this is the group of muscle which you are working, and each of these muscle will work in certain set of exercises. And when you are targeting those exercises to those muscles are worked out, and you automatically train the system for engaging the muscle in the right way. Reversibility principle, it also says that when there is training, the muscle learns. When you stop training the muscle, there is detraining, which means the muscle will stop working in the trained manner and will go to the habitual manner. So you need to keep on working at a particular thing. So maintenance phase is very important. It's like going to gym. So if you start working in a particular way, the muscle will start working correctly. Last is rest and recovery, which means, as I told you, it is fatigable. And so if you provide appropriate periods of rest, it will recover very well. The second is motor learning principles. It has two basic components, pre-phase and a practice phase. The pre-phase is your judgment about readiness of the person and what are the barriers of this person, because you are going to engage them in direct treatment. Unless the person is ready, you really cannot work with him. So what is the level of motivation? What is the level of taking instructions? What sort of explanations may work for this person? Can you provide the right sort of model? Can he understand the difference between what he is doing and the model he is seeing? What sort of perceptual training can we do? Is he an auditory person? Does he feel, is there the more kinesthetic feedback, or is the person more feeling kind of person? All these things are to be judged before you start the treatment. And when you are treating, you have to provide on what sort of practice, how much is the schedule, what type of practice you should do, how are you providing the feedback, and how much of feedback you provide. So all these have to be kept in mind, and you have to provide a clear prescription so that the person will know how to do the exercise, how often to do the exercise, and how he can progress with these exercises. Now let's come to these exercises in person. So as I told you, first one is relaxation. I believe in these 4 exercises which work on hyperfunction voice disorder, muscle tension, dysphonia. One is relaxation. So first in that, I look at 3 basic things. One is postural alignment, breathing, and circumlaryngeal massage. So the postural alignment is how is he sitting, how is he standing when he is engaging in conversation, what sort of posture is he there, how is his neck and head aligned to the trunk. So if you are fixing the posture, automatically the tension reduces. Many of these people, if you see, they will have very high raised shoulders. The shoulder will go on raising. They may have a very constrained posture. They will have their hands tied, the neck cramped, the shoulders brought inward or raised. So if you are directing them to the picture, you can either take a video, make them sit in front of a mirror, or watch videos, record the classroom, and then show them, and observe as the person is progressing in his class or speaking activity, how the posture changes. Can the person disengage with this altered, inappropriate posture? Second, we also will notice that many of them are upper chest breathers or higher chest breathers. So engaging the abdominal sort of breathing, taking deep breath and relaxing, keeping the lungs lowered, the larynx have to be pulled down, then automatically relaxation happens. Third is massage. You can either do with the 2 hands or 1 hand, and then either a circumlaryngeal massage or kneading massage can help. Basically, what you have to do is you have to increase the thyrohyoid space and cricothyroid space. If you can increase the space, automatically the muscles will get relaxed. So these are the relaxation exercises which can be done. Vocal function exercises, which is proposed by Stemple, it also works very well to reduce the hyperfunction. In that, the first step itself is very enough for you to work with muscle tension dysphonia. So gentle mobilization help resolve efficient function. So the tight adduction has to be replaced with gentle adduction. So as I told you, the adduction abduction should be alternatively done in a constant engaged tension, okay, which means your cricothyroid and thyroarytenoid are kept in constant tone. Only the lateral cricoarytenoid and posterior cricoarytenoid are alternatively engaged. A sustained phonation activity like a vowel E in a soft voice for a long duration with an adequate breath is enough for you to normalize the tension. So just say E is enough for the person to get into this normal mode. When he says A, tight adduction versus fluctuating tensions, that pattern has to be broken and the person has to be taught a gentle mobilization of the vocal fold. Resonant voice exercise is producing, focus on the sensory information, trying to keep the sound forward so that the stress is taken away from the vocal cord and it is brought forward and the sound is allowed to resonate in the resonating cavities. So this is again propagated by Verdolini, where they have said a lot of vocal fold impact stress reduces by keeping the sound forward. So usually I use consonant vowel combinations. I use the mom sort of drill and I ask the person to say mom, sort of a thing in slow manner, fast manner, loud sound, soft sound, so that the person gets the idea of keeping the sound front and not keeping on the level of vocal cord. The last exercise, which I believe which works very well to reduce hyperfunction and balances muscle, is semi-occluded vocal tract exercises. There are several semi-occluded vocal tract exercises. All of these can be used for reducing the tension. Very common exercises are lip and tongue drills, like, or nasal humming, saying, buzzing, okay? Or these days, which is more popular, is using a straw phonation or a straw blowing bubble exercises, where you take a glass of water, fill the glass with half or 50% of water, dip it allow a straw inside the half filled glass and then blow into the straw. Now, what you have to do is, most important is, you should not ask the person to bend his head. He has to keep the head straight, just like how he would talk. But you can bend the straw or the glass and then ask the person to seal the lip and blow into the straw at a constant speed so that you get a bubble. This bubble has to be maintained at a constant level. Automatically, there will be a back pressure which goes and it will normalize the muscle tension and balances the muscle function. So these are some of the direct exercises which can be worked on people to reduce hyperfunction, can be done for both primary muscle tension dysphonia or secondary muscle tension dysphonia. The third approach, which is more common, and I believe, is the eclectic voice therapy, which is a combination of these two. One of the published protocols is ours in 2021. Just 2 years back, we published this comprehensive voice habilitation program for hyperfunctional voice disorder. This is published in Journal of Voice. The treatment goals is to get an acceptable voice quality and an enduring voice. So what I'm trying to emphasize is hyperfunctional voice status or condition may not necessarily have a pathological manifestation. It can happen in any person, and these person, if they continue in the hyperfunctional voice state, will develop a disorder. So you can start therapy even when the person is showing hyperfunctional voice state, and that is for normal people as well. And the focus is not to have a clear voice, but an acceptable voice quality which is enduring, which means it can stand still for a long period of time. What are we focusing on? We focus on vocal hygiene, warm-up, cool-down exercises, gentle voice onset, which means a tight adduction should be eliminated, resonant exercises, flexibility exercises, and dynamic range exercise. And I've also given a set of carryover, which means certain set of sentences or phrases which allows a person to easily transit the learned behavior. The phonation is learned. How do you transfer that into speaking voice can be facilitated through these carryover exercises. So this is explained very detailedly in that paper. It's a long paper, but worth reading. It gives you a set of things which are possible for Indian population. Specific instructions on vocal hygiene which are applicable to our people, certain set of exercises which are easily followable for our people. Our people can follow these instructions, and the focus of the several steps have been explained in that. I've also given how to construct the session, how you should do warm up, what is a core exercise, and how you should do cool down. Warm up is basically stretching and laryngeal massage and SOVTEs with breathing exercise, usually for the first 5 minutes of the voice therapy. And then at whatever stage the person is, there may be a different set of exercises. You can combine many of them or you can go in a sequence. Cool down is passive stretching, basically allowing the system to rest or come back to a normal state of activity after you have engaged with a conscious purpose. The next part of my talk is what is available from our research. There are 2 RCTs which have happened as part of 2 students who have just completed their PhDs with me. One was on vocal hygiene program, another one was to compare with the voice exercise program. One we tried with any sort of vocal hyperfunction, and then we particularly tried with female school teachers. And both of these, we found that when you are combining both voice exercise program along with vocal hygiene program, we find better outcomes. So eclectic approach is found to be more beneficial than compared to any one of these approaches. So what I want you to remember is hyperfunctional voice use is basically a mal-regulatory dysphonia. It is because of a muscle imbalance that is resulting because of auditory and somatosensory feedback mechanism. It may not be always in voice diseases or disorders. It can happen in any normal person as well. So there is altered biomechanism of phonatory, respiratory, and sensory motor system and the personality traits, which can manifest as a non-phonotraumatic vocal hyperfunction, which is basically primary muscle tension dysphonia, or phonotraumatic vocal hyperfunction, which is a disease process, which is a secondary muscle tension dysphonia. An eclectic treatment works best for treating muscle tension dysphonias or vocal hyperfunction in general. I primarily want to highlight on these 4 references. One is a Journal of Voice, a recent one in 2020-22, which talks about the current understanding of vocal hyperfunction dysphonia, why we should not think it is just a functional dysphonia, but how the evidences are coming towards a malregulation of the sensory feedback, which could be auditory, as Dr. Subbiah said, or it could be more than auditory itself, and there is a psychomotor influence in the maintenance of the disease. The second thing is again a paper which we have published, Journal of Voice, which is basically an eclectic voice therapy program for treatment of hyperfunctional voice disorder, which is available in Journal of Voice. You can look at it. The other 2 are the RCTs, which are available in Sodh Ganga. All the PhD and dissertations are available in Sodh Ganga. Sodh Ganga is a free download. It's a portal of the UGC. So you can look at it and automatically you will. It's a repository. It's a national repository for all work in India, especially PhD thesis across all universities in the country. So these two are again available there. You can look at it. It will give you a detail. There's a manual attached also. If you look at it, you will get an idea of how to do these therapy. Thank you very much for this opportunity. And I'm happy to discuss more on this.
Thank you so much, sir. I'm actually spellbound. I don't know what to say. Both the speakers have rocked it, and the way you both have designed yourself, I don't know, it was combined and you spoke to each other and made it or not. But as an ENT perspective, he made very sure that how the diagnosis can be made. And actually, the patients come from the ENT doctor. And then it was continued to a speech therapist view after they come from the ENT doctor, how a speech therapist can proceed to it. And both the speakers had spoken so well, like you were talking to babies. So that it was so soothing, and all the participants, I think, really could get every point directly into their head. And I would also wanted to mention that every slide of both the speakers can itself be another 20 minutes or 30 minutes presentation. So I'm very happy for all the participants who got an overview of the excellent research of both the doctors who are doing a lot of work in voice. And as speech therapists, I think we might be exposed and doing all these things a little bit, but we don't know the reason behind why we do these exercises or how we treat the postures and things like that. We try to do it, but we don't know the main reason behind it. But today we got an excellent view of why and how and what else we can do on these patients. And here I would like to welcome Sirisha ma'am for her excellent views on voice cases. I don't know, her clinical practice would be much more than many of us. So I would like to introduce our Sirisha ma'am as an audiologist and speech language pathologist, founder of APASLPA Association, advisory member, present advisory member, bachelor's she has done in AVG NHH, SRC Secunderabad 1999 and 2003, master's in Helen Keller's 2008. She worked in Government General Hospital, Guntur for a period of 12 years. During that time, attended more than 50 camps. She's an ex-consultant for Lalita Super Specialty Hospital and present consultant to Ramesh Hospitals, Guntur. She's an MD of Snehal Speech and Hearing Rehabilitation Center. Ma'am, here we would like to ask you for your view of the patients who come to your clinic and how do you deal with these patients after getting this overview of MTD, and how do you consider these patients and treat
First
them?
of all, good afternoon, everyone, and I wish everyone the World Voice Day. And I'm very grateful to listen to the lecture of the Subbiah sir and even the Prakash Boominathan sir. Sir, thank you for the very helpful lectures. And ma'am, coming to this thing, I have been working with Parendra Kumar sir for the past 15 years, and whenever the voice therapy, whenever the patient needs the voice therapy, so sir would first tell me to deal with the pre-therapy, pre-therapy for them. So I would like to share my experience with one of the patient. Actually, he's an young theater artist who is aged 27 years or 25 years. I roughly remember his age. So he's a theater artist in Mumbai, and he has a hoarseness in voice for the past 2 years. So he has been to many therapy clinics in Mumbai, and but his problem didn't resolve. So finally, he came to Guntur to consult Parendra Kumar sir, thinking that he has a major issue with his vocal folds. So then sir examined the the theater artist. So sir could not find any any changes, any pathological conditions in his vocal folds. So he asked me to give the voice therapy for him. So actually he has prepared to come for one month to resolve his problem to Guntur. So I have given him, as sir said, I mean, as many of these sir said, actually he doesn't have any pathological condition because he doesn't have any vocal knowledge or any other problems. So but he has a psychological problem. Like, as he's an younger theater artist, so he's more worried about his voice, like how he is presenting in the theater, whether the patients or I mean, sorry, not the patient, whether whether he what to say, whether he could rightly present his voice or not. So firstly, I have gone through the clear cut history of him. So in that, mainly in voice therapy, for us, most of the diagnosis we can come with we will get through case history only. That means the clinician should be expert in interviewing skills. So we should ask his previous history of any upper respiratory tract infections, and or any psychological traumas he has gone, and what is his profession. I mean, as sir said, we should ask him is about his occupational skills and remaining. So then I asked him, as I found that he is of more in psychological trauma, as he is a younger theater artist. So and his neck positions, and as sir said, for the many of the patients, first we should check up the posture. We should check the posture of the patient, like how he is holding his neck, how the jaw, how his jaw movements, or like how he is sitting and all. So when I observe the patient, so he is always dropping his head forward, and he's leaning forward whenever he's talking. So first, then I worked on his neck muscles and the muscle tension. So I said him the exercises, like neck exercises, to and I also worked on his breathing pattern, because his phonation duration is very less. So after 2-3 weeks of voice therapy, so he has become normal. So he himself is shocked, like that, how come I have been so many to many centers, how my voice has not been improved prior, and now is it because sometimes even the small changes in the small exercises also can improve the symptoms in the patients. So this is one example I have. I just wanted to share, ma'am.
Okay, thank you so much, ma'am, for the for sharing your patient's experience. Yes, sometimes small changes are the best things we can do, and they achieve a lot out of it. And sometimes it could be that, many doctors treat over a period of time and the result comes a little late. By the time they come to our hands, the result is there. So yes, it is different in a different perspective.
And even the counseling also plays a very important role, I feel. The counseling of the patient.
Definitely, ma'am. As the speakers always told, psychological issues, environmental issues have to be handled. Yes, counseling and talking to them, making it personal for them, will release a lot of tensions. Yes. Personally, today I'm very happy to listen about muzzle. We generally think of nodules, palsies, but today we need to learn. We understood that we need to talk and learn more about what is happening inside the muzzle and how to strengthen the muzzle. Thank you so much, ma'am. And here I would like to introduce our other panelist for us. And yes, he's Mr. N. Rajshekar Reddy, working at AAG Hospitals, completed Masters from Helen Keller's with working experience of 14 years at MedCity Star, Nova Specialist Hospital in both audiology and voice therapy. We can see your simplicity here, sir, by the by the way you've given your biodata, but I'm sure you must be having a better view about these patients. And over to you, sir. Please share your view.
Thank you, madam. It was a wonderful presentation from both the speakers, Subbiah sir and Prakash Boominathan sir. Like it gives very detailed things in the perspective of voice, but I just want to share the view of practical opinion. Whenever, like, I'm already associated with Dr. Srinivas Kishore, he's an ENT. So as there is a close association with him, and I'll be working the patients of voice, I could say one thing in a practical sense, what Subbiah sir said, like to have the auditory feedback, that is much more important. Like, first of all, when the patient is there to you, rule out how much he is really showing functional aphonia component in it. That means functional aspect of voice need to be ruled out. Otherwise, you will be misjudging the patient, and you will be like keep on trying one after the other exercises. So what lumbar effect will help you, what I personally tried is, the lumbar effects will give you an idea how much functionality is being added by the person to the exact problem, what he's facing. So it is in a practical sense, it is much more helpful. So when the patient comes to you and when he is speaking to you, observe his characteristics and what kind of voice he is deliberating. So then you try to apply the lumbar effect on the patient after teaching basic exercises of whatever the phonation usually the people do. Then keep the lumbar effect principle and again watch the same phonation exercises, how the patient is doing. If you find the change in the phonation, definitely he is adding up the functional component to some or the maximum extent. If the problem underlying problem is much higher, usually to shift the pitch or to loudness is very difficult for the patient. That's where you will get half of the idea. Then after understanding the patient, then according to my practical view, it is like to understand the pitch of the patient. I usually ask, do you have any previous audio of your voice, like recorded in the phone or talking to the family members or talking to anyone? Then if I'll see what might be his previous pitch in which he was speaking, let know how much tension he is adding on that, and now what is the present phenomena in which he is speaking. So while after observing that, then I'll come to the conclusion, the basic principles for all the exercises will be almost all the disorders. There will be some kind of muscle tension will be underlying principle. So you need to make the person to speak in an appropriate pitch is a much more important aspect, as I feel personally. It might not be a generalized concept, but I feel you need to keep the patient in a proper pitch, because as a problem the patient is facing, he might be speaking in lower volume, the different pitch, or in a much more granted way, such a kind of thing. If you could make him to produce a voice of much more single voice phenomena, like I can say, instead of diplophonic voices or a grunting voice or a very hoarse voice kind of thing, if you could bring the patient to much single voice phenomena, then it will be helping the patient to understand, yes, I can change my voice. This is where the first step of motivation comes to the patient. If you see, the only way by counseling, it helps you in motivation, but if you could show some change in your session, at least in your first session, you can't change major change, but you can give him that promise that, yeah, your voice can change, and it can definitely help you to understand that this therapist can really help me on. Usually the person will turn out, until unless like he is not interested. The patient motivation is also much more important, except the therapist motivation. So if I feel if you could counsel the patient for longer duration or the required amount of sessions, and if you could show the proper results, he will be definitely improving. In my scenario, the patients who has followed up me for the sessions which we have planned, and sometimes it might take longer time also, it has shown a very interesting results, and it has changed their voice. After changing their voice, I'll ask them to sustain the same voice for at least 2 to 3 months by practicing the exercises, at least for the for professional voice users like teachers. I'll ask them to use this vocal warm-up exercises for a longer duration of the period throughout their life, and following the lifestyle thing of for drinking the hydration for 15 to 20 minutes, every 15 to 20 minutes, then not to reach very high variations in their pitch initially. Once the voice is saturated, then they can use this variations in pitch, and also not to eat much like oily food or spicy food in the nights. Especially you can have it in the afternoons sometimes because if it is unavoidable situations, but mostly you need to avoid the oily food or spicy food in the nights, as it provide you, if the patients with GERD will have much more problematic, and also it also creates some kind of reflexes, as it is a trigger for most of the muscle tension dysphonias. So the techniques, most of the time, the voice therapists have a doubts, like whether whatever I'm doing is correct or not, because it comes with an experience. It doesn't come just like that. What I ask each and every voice therapist is, please try to stick on to your basics. The basics will help you definitely in understanding the patient voice, and it will also give you the confidence. Okay. And in my scenario, resonant voice exercises has helped me a lot in understanding the patient voice as well as improving the patient voice. Even the patient could easily follow the resonant voice exercises. That's all I could say. Rest all has been said by speakers, and Sirisha madam also has shared her experience for the cases. So this is my general what I deal with the patients and how I treat my patients. If first initially I'll be seeing the video of the flexible laryngoscope. Then after post finishing of my therapy also, I'll ask my ENT to just to record the video of flexible laryngoscope. Then I will understand like up to what level I am succeeded. Otherwise, I will not have idea whether I have shown a very drastic, very good improvement, and whether the patient need to follow the same exercise for how much amount of the time, so that I can give him the prognosis guidance for the latter period of the time if the patient could not stay with me for a longer duration. That's it. Thank you.
Thank you so much, sir, for sharing your view and your techniques. So now I understand that I think every therapist or speech therapist will have their own signature treatment procedures or assessment treatment procedures. And today we got the view of 4 different expert voice pathologists signature treatment procedures and assessment procedures, and the present research, what is happening around us. And I also thank the participants for their patience and participating on a Sunday and waiting and listening to all these things. So now I would like to come to the end of question answer session. If the speakers are ready, I would like to ask them a few questions which are there in the chat box.
Yes.
Sir, the 2 main questions are, one is, can we train the muscle individually, because there are junk of lot of muscles, hypoglossal, cricothyroid, everything, insertion and origin are in different directions all around. So when you're touching the neck and giving clockwise or anti-clockwise or pressurizing at a particular point, can we really individualize the muscle? Is there any technique particularly for that? Or if at all we are touching the bulk of the muscle, how do, as a therapist or voice therapist, understand that we are not abusing the muscle and we are only gently strengthening the muscle? I think the second speaker could answer this because he spoke more on treatment.
So is this addressed to me?
Yes, sir.
Okay. So we can train muscles individually. So it's very important for us to know the anatomy correctly. Okay. And when you are touching the muscle, you will be having a feel of. See, perilaryngeal muscles is what you can manipulate. The intrinsic muscles are manipulated by the vocal functions only. So there are two groups of muscles, the extrinsic muscle and the intrinsic muscle. The extrinsic muscles can be dealt with a little massage. The intrinsic muscles are handled only by activities of the voice function. So as I told you, the vocal function exercises are directly dealing with intrinsic muscle. So when you are sustaining a phonation in a soft volume, you are activating the LCA and PCA, lateral cricoarytenoid and posterior cricoarytenoid. And when you are rising the pitch from low to high, you are relatively engaging the cricothyroid and disengaging the thyroarytenoid. When you go on the other way, from high pitch to low pitch, you engage the thyroarytenoid and relatively disengage the cricothyroid. So these are the four activities which the vocal cords are capable of, and vocal function exercise basically works on this principle only. Okay. The massage which you are talking about is for the perilaryngeal muscles or muscles of the neck and shoulders. And all of these are interconnected, and you need to fix the laryngeal position. So extrinsic muscles are worked basically to fix the laryngeal position so that the vocal cords, the muscles do not progressively cramp and keep the vocal cord elevated. If the vocal larynx goes on towards the chin, then the hyperfunction will increase. It has to come down. Laryngeal descent has to be facilitated. For that, you need to work. And for all the muscles, infrahyoid muscles have to be relaxed for you to keep the vocal cord or the larynx down. Suprahyoid muscles need not be worked on. Suprahyoid muscles have to work just to behave properly. This is the way you work on these muscles, and specific muscles can be worked on for you to maintain the tension and the laryngeal position.
Okay, sir. Thank you so much. I think the same will go good for another question which says examples for flexibility and dynamic range of exercises. I think the same answer can go good for it. So
What is the question?
Examples of flexibility and dynamic range of exercises.
So dynamic range refers to volume. Okay, volume is basically soft voice and loud voice. So dynamic range is completely brought through aerodynamic activities, with the help of air flow. You are not involving the muscle there. Okay, dynamic range activities are basically trying to regulate the airflow. Okay, so if you are having wide mouth open, which means you can allow a lot more air to come, then most often times the volume will be louder. If you have a clenched mouth and you are not allowing a lot of air to come, there is no passage, then automatically voice gets softer. Okay. Volume is regulated by three activities: how far the vocal cord is open, and how fast the vocal cord is closing, and the degree of openness of the vocal tract. So all these three are addressed in dynamic range activities. So you please refer to my article where I have specifically given certain exercises to activate these different levels. What you should do for increasing or controlling the flow, what you should do to expand the lateral excursion of the vocal cord, and how you can reduce or increase the speed of closure. That is the tempo. So these are dynamic range exercises. Flexibility exercises are to do with the vocal tone. Okay, so that is how you can maintain a pitch. How can you maintain a high pitch? How can you maintain a low pitch? How can you transit from a low to a high pitch, high to a low pitch? Transit registers, okay? Intonations, when you're talking, there should be ups and downs, and these should not sound staccatic, or it should not sound tremulous. When we are tensed, or when a person is very old, this flexibility is lost. So for that, you need to engage the muscle. So when you are working with the principles of exercise physiology, what you should remember is you should know the function of the muscle. What does the muscle do? What are the relative constraints of that muscle? You should keep other activities neutral and work only on that muscle alone. For an example, if you want to increase the pitch range, okay, the person is not able to go for a higher pitch and is not able to maintain the higher pitch range. So you have to concentrate on only engaging the cricothyroid muscle. The cricothyroid muscle has to be worked out for you to achieve the higher pitch range. Now, when you want to do that, you want to keep the volume constant, the flow constant, neck tension constant, and then only increase the pitch or the tone. Then automatically that muscle alone will be worked out. There also you start with shorter duration, longer duration, slower tempo, faster tempo. Then automatically you will be engaging the muscle. So please compare all the vocal exercise to physical exercises. When you go and work on a gym to increase your bicep, all other muscles will be kept. The exercise only will be to increase the bicep mass or bicep shape. So that alone only will work. So other things are neutralized. Same thing you should do for voice exercises also.
So isolation.
I hope I have answered the question raised by the person. I don't know if this is the question.
Yes, sir. Miss Namita Daniel has asked this question, and you were talking about the isolation of the muzzle, even opening the jaw for the dynamic range. The muzzle has to be activated to open to a particular range. And there's one more question, sir, since we are coming to the end of the session. It says, we as professional voice users, speech language pathologists, we also rather privileged to have hyperfunctional voice disorders. How can we self-secure being a therapist for oneself?
It's not a privilege, it's a disadvantage. Right? We are also susceptible for hyperfunction voice disorders. Speech language pathologists are also vulnerable for breakdown of voice because we engage in continuous talking. We deal with children, adults, and sometimes not really comfortable environments. Sometimes therapy rooms can be quite noisy. Waiting spaces will be near the therapy rooms. Children can be noisy, so it works. And we have back-to-back sessions and vocal loading increases. So what is the thing is we should not be preaching, but actually practicing. Whatever we read, we have to practice. So drink water, follow vocal hygiene, do these vocal warm-up exercises regularly, and learn to speak in a comfortable way which suits your body. The moment you engage the system correctly, then it becomes much comfortable for the person to speak. The vocal mechanism is meant for using. Okay, so you can go on talking for how many hours required, but talk at a comfortable pace and in a comfortable environment. Only when you are exerting, then it becomes tired. First thing you should remember is ensure that there is no noise in your therapy. Background noise, reduce. Fan could be a big noise maker. So reduce the fan speed or, find ways to distance the noise from your therapy. Second is regularly hydrate yourself, take small breaks in between. When you finish your counseling session and start your next session, please give yourself 5 minutes or 7 minutes break so that your system will recover. Don't eat fried, oiled items in between. Eat healthy so that automatically you don't have influences of acidity and other things. So whatever we preach to our patient, we should follow. If you follow, I think we will all stay healthy. And in a way that we are in advantaged position because you know the science behind how to use the voice. So you should use. We will also come under professional voice users, which category most likely level 3.
Thank you so much, sir, for giving a good review on speech language pathologists and level 3 voice users. I hope Safina ma'am got her answers. And I would like to ask a small question to Sanjay Subbiah sir as an ENT specialist. Sir, many a times we get ENT specialist references saying that it's vocal cord palsy or vocal nodule is there, early vocal nodule, so treat it. So many a times it won't be mentioned as MTD or even abuse. They won't talk about in the history whether they have undergone abuse or anything of that sort. And they directly give some steroids and then they send it to speech therapy. Sometimes it's a big challenge for us. We don't understand how to assess subjectively, objectively, and what is the effect of steroid on that particular muscles. And how if at all steroid is induced, should we change our therapy interventions? Or if without steroid, we can still go ahead and do the same kind of exercises. Basically, an effect of steroid. Please, sir.
Yeah, okay, thank you. I mean, from what I understand is your question is if a person is started on steroid. See, in my thing, basically steroid indicated in an acute trauma. If there is a voice professional who has a performance and now there is some mucosal edema, mid-mucosal edema, they want to, but they can't cancel their program. In such a case, in acute injury, it will help. In vocal hemorrhage also, along with voice rest, you give steroids, acute injury, it helps. So if there's acute, so basically, so in acute injury, there are two things, the lesion per se and the associated muscle tension dysphonia. So if there is hemorrhage or like this, there is a performance and they have given steroids, wait for 3-4 days, let the issues resolve. In the meantime, you can do all the counseling part, breathing exercises part, you can do that, the relaxation, diaphragmatic abdominal breathing and those exercises you can do. And after all this the acute stage is over and the steroids are stopped, and then afterwards you can do your other part, like whatever Prakash mentioned. And then another thing, long-term steroids indirectly will affect the muscles. So frequent, just 1 or 2 days, 3 days max is what is you can give steroids, I feel. So in acute condition, you just counsel and do breathing exercise. Don't give them any task to strengthen the muscles or those type of exercises. After the acute condition is over, you can do your then whatever therapy you want.
One more addition, it all comes here with your experience also. It doesn't like only how could you know it is a muscle tension dysphonia. It all comes with your experience, how to identify it. It is not identified with someone person or ENT. It is not definitely necessary that he would identify it as an MTD in some cases. Sometimes it may be misdiagnosed also. You should also have your own experience in diagnosing the condition and treat it. Okay?
Sure, sir. Thank you so much.
Yeah, I do agree that many ENT surgeons do not know. So don't look for ENT surgeons mentioning that muscle tension. If it is there or no, you do your own assessment. I agree with Dr. Reddy that, and then if there is muscle tension, they will think.
Thank you so much, sir. I think we will end this session. APASLPA should tell us, is there time for some more questions, or we are okay?
One more question is there, ma'am.
Okay. Yeah, there's one more question, sir, if you're okay and the time is okay for APASLPA. It says, sir, according to classification by Kaufman and Isaacson, we SLPs are level 2 voice users. They have a query there.
So
I'm asking because I'm giving presentation at 10. Yeah, go ahead.
Right. Isaacson's and Kaufman's classification, Kaufman and Isaacson classification is based on the level of training and relative risk of developing a voice problem. Okay, so what sort of training goes? What is the risk of you developing a voice problem and losing a job? Okay, so this is how these are the logic for. So level 1 is elite vocal performers, which means they are highly trained and they are at a high risk of losing the job if they have a voice problem. Level 2 have no formal training. By virtue of the job, they have some amount of training, okay, on the voice use. And they may lose the job if they do not have. So it's like, say, for example, level 1 will be singers, drama artists, theater performers. Level 2 will be all the pujari, when they recite Veda. So they have a particular style of reciting. So by virtue of their job, there is a training. Clergy, okay, in the church they learn to sing also. Level 3 people are who do not have training but may have information about voice use. Okay, and they will not lose a job but will have an effect on their job. So teachers, all these will come under level 3. So I most often time think speech language pathologists, though we may know about voice problem and relative risk, all those things, we are not taught how to use voice, right? Is there any formal training for us to use voice in the therapy room? So we don't have any formal training. Okay, by virtue of the job, you may learn. So there could be always the confusion of saying whether we are level 2 or level 3. I would prefer to group it under level 3. You will not lose a job. You will, no time you will lose your job as speech pathologist or audiologist because your voice is bad. You may temporarily cease to function for some days till the voice is. So I think otherwise your skills will still go. You will do home plans. You can do many things, which, so I would prefer to call it level 3 only. So level 2, level 3 is always a confusion, but this is the logic. So we should remember 3 things. What is the training they have had for using the voice? What is the relative risk of developing a voice disorder? When they develop a voice disorder, what is the relative risk of losing the job or changing the profession? Okay. Level 4 is people who have no training, no risk of developing a voice problem, no job. So they are like clerk, anybody who is on a desk job. There is no training, there is no problem for him to use a voice. So speech language pathologists can be called, say, probably if you are a singing voice specialist, okay, then I would think you possibly will fall under level 2. But if you are an average, if any of us are just dealing with child language disorder, or if you are a teacher in a college or a clinical supervisor, then many times I would think we would fall into level 3. Okay.
Thank you so much.
Does it clarify? Whoever asked the question.
It gave a very deep insight about how to elaborate or differentiate type 2 and type 3.
Right.
So, and yes,
these are flexible. There is nothing hard and fast.
Yes,
it's flexible. It's relative.
It depends on the points we have. Yeah, here I would conclude this session. Thank you so much, APASLPA. I don't know how did you select these speakers, from where did you bring these people? Excellent way of designing the way, how do you look at anatomy and physiology and the treatment part? I hope it helped the participants a lot. And here I would like to ask a small note from our president of APASLPA to give a small thank you note to our speakers, please.
Thank you, madam. Thank you for giving the mic to me. First of all, happy Voice Day. It's a very precious thing, gift from God, that our human beings are speaking, we are expressing our feelings, our emotions, our etc. in the voice, which the God only as human beings have this thing. Okay, and on the occasion of this Voice Day, I think we are providing an excellent services to the persons who are suffering with the voice problems. Like these occasions are very important for us to share and upgrade the knowledge on the specific disorders. I would like to thank the presenters for accepting our invitation and being here and spending the time and sharing the valuable thoughts and techniques with us. Thank you very much. And thank you for the panelists who are sharing their experiences and giving the inputs to our participants. Definitely, these inputs will be helping us in our daily practicing in the specific disorders. I would like to thank each and everyone for participating in this occasion. Happy Voice Day, and use the voice. Not the least, use the voice preciously, which is very much helpful for us in many aspects of the things. Don't misuse the vocal abuse. Thank you very much.
Thank you, sir. So we will look forward to more webinars like this and special topics and speakers who can.
Thank you everyone for having me on, sir. Thank you very much. Bye.
Thank you very much, sir. Thank you one and all.
Thank you, sir. And yes,
Thank you one and all for giving me.
Thank you, Prakash, sir.
Thank you. It was a pleasure to meet everyone. It was very nice to share the dais with, the online platform with Dr. Sanjay after a long time. Okay, thank you very much. It's so nice to see several friends in Andhra Pradesh. I may not have met you all in person, but a few of them, at least by name, I know. So it's very nice. So, looking forward to meeting you all in person some other opportunity, maybe in Andhra Pradesh, and or when you guys come to Calcutta for the next ISHA conference, where I'll take over as president. Thank you very much. Thanks for the opportunity.
Thank you so much for the speakers and panelists and the coordinators, Sucharitha and the secretary Gopi. And yes, we are ready to end the session. Thank you all.
Last but not the least, I would like to thank Lakshmi ma'am for moderating this webinar. Thank you so much, ma'am. And thank you all for this, even on Sundays pairing with us. Thank you so much, sir. And thank you so much, ma'am. Thank you.
All good. Bye.
Thank you very much.
Jai Hind.